This is Dr. Carol Rosenberg. She's an internist at North Shore up in the north side of Chicago. She's the founder and program director of the Living in the Future or Life Cancer Survivorship Program. This has been funded by Livestrong. She's also an NIH-funded researcher. She had funding for the Women's Health Initiative, which was a big undertaking. She's been a clinician for over 30 years, also a medical educator, very involved with the North Shore Community Network. So with that, I'll turn it over to Dr. Rosenberg. So thank you.
Hello, everybody. As Dr. Golden said, I'm Dr. Carol Rosenberg, and I am the director of the Living in the Future Life Cancer Survivorship Program for North Shore University Health System. And excuse me, I hope that you've had the opportunity to watch the video and look at some of the resources prior to this, the course. So even though I founded the Life Cancer Survivorship Program over 15 years ago, survivorship is really still the new frontier in the cancer care continuum. And with progress in treating cancer comes a new and unique challenge for healthcare, and that is ensuring the health and well-being of the over 15 million cancer survivors in the United States, all living in the future. And you are here today really because surveys from the National Cancer Institute have determined that less than 10% of non-oncology health professionals are familiar with the most common late effects of cancer and its treatment. Health professionals don't feel comfortable integrating and adjusting cancer survivors' healthcare needs to medical practice, mostly because they never learned about it in medical school. So I'm going to begin the Science of Survivorship course by telling you why I'm the one that teaches it. And I think that, and give you some of my background, which creates my expertise so that we are going to work together to create your expertise. So I'm as Dr. Golden mentioned, I'm a clinician. I've worked in the clinical environment for over 40 years, and I'm a clinical researcher, having been a principal investigator for something called the Women's Health Initiative. And my area of collaborative research is actually in cancer risk prediction in postmenopausal women, and the particular area that I worked in is second cancer risk. And I'm also the mom of an adult survivor of childhood cancer who is now a pediatric health professional herself. So I take all these perspectives, the clinical, the research, and the personal perspective to bring forth this course for you today. So we're gonna define the status of cancer survivorship in the United States. We're gonna identify actual and potential post-treatment effects for different cancer types. We're going to discuss the role of the healthcare professional in the provision of healthcare. So really, we're going to help you create a prescription for survivorship, even in your young and rising and evolving health professional education. So I want to introduce you to the late Fitzhugh Mullen. And Fitzhugh Mullen was the co-founder of the National Coalition for Cancer Survivors. And as a young physician in 1975, Fitz was diagnosed with cancer at a time when a cancer diagnosis was often kept secret, and especially from friends, family, and coworkers. And in 1980, I had just graduated from med school and started my residency. And I was on the oncology rotation, and my attending showed me this correspondence from Fitzhugh Mullen, who at this time was a young attending himself. Cancer therapists talk in terms of a 5-year survival rate, by which they mean the number of patients with a given tumor who will live 5 years beyond the time of diagnosis. It's an arbitrary way of measuring human existence, but useful for scoring the likelihood of escape from cancer. In mid-March 1980, I tiptoed past the invisible line and into the future. And so really, a full 10 years after his own cancer, Fritz wrote a seminal article in the New England Journal of Medicine and talked about the seasons of survival and reflections. And it was really a catalyst for our recognition that survivorship went well beyond cancer and treatment and the 5-year survival rate. And he says, it's as if we have invented sophisticated techniques to save people from drowning, but once they've been pulled from the water, we leave them on the dock to cough and splutter on their own, and in the belief that we have done all that we can. And so really our job and the Living in the Future Cancer Survivorship Program is really named after tiptoeing past that invisible line and helping our patients look through the road ahead. So who's a cancer survivor? Technically, a cancer survivor is anyone who's been diagnosed with cancer from the time of their diagnosis through the balance of his or her life. And why should we even care about cancer survivorship? Well, basically, to sum this slide up, there are a lot of them. The number of cancer survivors has grown tremendously. And here you can see that really the state of the art is that cancer care is suffering from its own success. Patients are living longer and surviving longer with their cancers. This very nicely delineated graph shows you that as the number of cancer survivors increases, we are experiencing longer and larger groups of patients in the senior over 50 age group. And at the same time, the 5-year survival rate for children who are living beyond their cancer is 80%, and the 10-year survival rate is 75%. And I know that Dr. Henderson will be talking to you about that in her lecture. But what we need to keep in mind that as children age and graduate from the world of pediatric care, adult care practitioners must become more knowledgeable about the late treatment effects and how to manage them. And the reality of cancer care today is really that there's a huge cohort of baby boomers who are entering the cancer-prone years, and the aging US population is going to result in what we call the silver tsunami of cancer survivors. And there are going to be fewer oncologists to care for these survivors, and we really need to train diverse healthcare types of healthcare professionals to care for the survivors. Now, I really love this slide because what this really emphasizes is the problem, and it's something that we're trying to fix in terms of educating healthcare professionals. And this beautiful survey done by one of your predecessors, Dr. Osvarek, is evaluated University of Chicago among the University of Chicago M4s. And this quote from the one of the M4s is really the one I like the best, which is, "I had no exposure to cancer survivorship care. Frankly, I don't think I can even define it, let alone delineate it from other oncologic care." So what our goal is today in our time together is for me to teach you a approach, a conceptual framework to handle survivors, whether they're a baby boomer with prostate cancer or a 40-something who had testicular cancer, or a postmenopausal woman with breast cancer, or 100-year-old Minnie with colon cancer, or the child who now becomes the young adult. We all need to help our patients straighten out the circumloquacious kind of road after treatment. So there are 3 stages of cancer survivorship: living with cancer, living through cancer, and living beyond cancer, which is the post-treatment and long-term survivorship. And this is the area that we're going to talk most about today. So what are the primary medical issues for that stage of survivorship? They are pretty much 4 areas. And as you will see in my PowerPoint presentations, if it's in yellow, it's something I want you to pay attention to. So prevention of recurrence in new primaries. surveillance for spread, recurrence, and new primaries, assessment and intervention for medical and psychological long-term and late effects of treatment, and coordination of care. So I call this the price of survival, which are the long-term and late effects. So a little definition on what is a long-term effect. Long-term effects refer to any side effect or complication of a treatment for which a person with cancer must compensate, also known as a persistent effect, but the main point is that it begins during treatment and may continue beyond the end of treatment. So let's take, for example, our postmenopausal patient with a survivor with breast cancer. She's 60. She's a breast cancer survivor. She had a right mastectomy, reconstruction, and chemotherapy consisting of 6 cycles of ACT. I'm just going to tell you now, ACT is adriamycin, cyclophosphamide, and Taxol. It's just the way we abbreviate it. It's a common type of chemotherapy treatment. And an aromatase inhibitor, which is a type of endocrine therapy that we use in breast cancer for a prolonged period of time. And this, she had stage 2 estrogen receptor positive breast cancer. And you are the physician, the non-oncology physician, you're her primary care physician, and you are seeing her in clinic, and you've spoken to her 3 times in the past week to discuss her elevated lipid profile, her cholesterol level, and her need for statin medication adjustment. And she seems unable to retain the information, and she complains of joint and muscle achiness. So here we're faced with the complexities of care. What is this? Is this cognitive dysfunction because she had chemotherapy and it's something called chemo brain? Is it fatigue or a sleep disturbance or depression? Is it a brain met from her cancer? Is it a transient ischemic attack, also known as a mini stroke or TIA? Or is it an aromatase inhibitor related joint ache, which commonly is something that can happen? Or is it related to statin drug toxicity, which is also caused that? So we need to be able to know and anticipate what treatments give what kind of effects later in the course of survivorship. So what's a late effect of cancer treatment as opposed to the long-term effect? Those are unrecognized toxicities that really are not there at the end of therapy or subclinical, and then they become manifest later on. And that's more common in multimodal treatments, and pretty much almost everything is a multimodal treatment given over an extended period of time. So we're really looking at the entire body, and we're looking at long-term and late effects that can either have malignant potential or non-malignant potential. We use breast cancer treatment as a sample of multimodal treatment and late and long-term effects because it is kind of a classic example. In breast cancer, we do surgery, we have lymph node dissection, we have chest radiation, we have anthracycline use, which is a type of chemotherapy, we have trastuzumab, which is a targeted agent, and we have endocrine therapy. So let's take a late effect and clinical pearl, and here is what my conceptual framework is when we are dealing with survivors post-treatment. There are 3 areas that you need to kind of get down, and that is anticipation. Actually, anticipation is a really important thing. There is the assessment, and then there's the identification of these late effects. So for example, Mrs. Cohn is an otherwise healthy postmenopausal 45-year-old Caucasian female, and she was diagnosed with left breast cancer at the age of 30. So we can all appreciate this was 15 years ago. You can also appreciate that she was young at the time of her diagnosis, and she underwent a left breast cancer surgery, chemotherapy, and radiation at another hospital, but she can't provide you with any other details. And she's admitted to your unit. Let's say you're an intern or any kind of health professional who's on call. Usually that means you're an intern. And she's admitted for observation following an open reduction internal fixation of a left wrist fracture. So nothing to do with anything that has to do with cancer. And at 9 o'clock, she develops shortness of breath and pedal edema. And once you get through your clinicals, you'll know that shortness of breath and pedal edema, that pedal edema means foot swelling, are signs that something is going on either with the heart, like congestive heart failure or a pulmonary embolus. And so the very astute intern gets a chest PE protocol, a CT of the chest, a CAT scan, and a MUGA scan, which shows that there is indeed an ejection fraction which is diminished and requiring treatment for congestive heart failure. Now, this is the area which is the conceptual framework. You need, as healthcare professionals of any specialty, to anticipate late effects from cancer and its treatment. So in this, there are 5 points to be made in this particular case. Left-sided chest radiation therapy and some types of chemotherapy are risk factors for cardiac dysfunction. Cardiomyopathy, which is a pathology of the cardiac muscle, a weakening of the cardiac muscle, can be related to prior anthracycline chemotherapy exposure. That's a known late effect of anthracycline. Premature menopause can accelerate the onset of cardiovascular disease and osteoporotic fracture. And this lady, the chemotherapies and the hormonal agents instill a premature menopause earlier than it ought to be. An axillary lymph node dissection or axillary radiation impose a lifetime risk for the development of arm lymphedema, and this individual had a risk fracture, so this person should be on lymphedema precautions. And the minute we see that somebody had breast cancer at the age of 30, early age at onset, breast cancer may be a red flag for a BRCA1 or 2 mutation, which we're going to talk about later. But there are 5 points here, things that we need to think about that are far away, but yet close to what is going on with her at this moment, which is not cancer. So let's talk about one of the late effects that is really important to think about, and that is recurrence or development of second cancers. Now, there's a difference. The possibility that a cancer will recur or metastasize is based on the biology of the disease, the stage or the tumor of the tumor diagnosis, and the treatments used. But when we look at developing a second cancer in a cancer survivor, we need to think about it's higher among younger patients, people who have genetic predisposition. It could be treatment related. It could be environmental factors. And so I want to present to you this example, which will show you about a late effect, which is second cancer. This Taylor's 42. She was diagnosed with breast cancer 2 years ago. So time course there is the reason that it's highlighted in yellow. She had a lumpectomy with a sentinel node biopsy, and she received 4 cycles of adriamycin and cyclophosphamide, 2 of those agents we talked about in the previous case, followed by whole breast radiation. And she comes to the emergency room with a 3-day history of a fever over 101. And she knows some gradual onset of fatigue over the past 2 to 3 weeks. So again, this is a fever, but her cancer was, of course, 2 years ago. And the typical kind of workup we do for a fever in the emergency room is a blood culture, a chest x-ray, a urinalysis, and a complete blood count. And I know that you have not had much laboratory or clinical exposure yet in your evolving medical career, but here this complete blood count shows a white count of 50,000, which is high, very high, and a hemoglobin of 8, which is low, and platelets of 25,000, which is very low. And here we see that this individual has a diagnosis of acute myelogenous leukemia. And the leukemia is a very rare occurrence as a consequence of treatment, adjuvant treatment, but we see latency periods, long latency periods when cyclophosphamide is involved, 3 to 7 years, or in the case of anthracyclines, which this was probably the case for her, the latency period is 1 to 2 years. So it hits us when we're least expecting it, the second cancer. So how can we talk about second cancers and genes and genetics? So hereditary breast and ovarian cancer syndrome, lovingly called HBOC syndrome, is related to the BRCA gene. The most common gene mutation is BRCA1 and 2. It's an autosomal dominant germline mutation, and there are other associated cancers besides breast and ovarian cancer, among them pancreas, prostate, melanoma, a fact that we don't really think about too much, but these are also in men. BRCA mutations can impart cancer risk in men too. And the prevalence in breast cancer survivors is about 5 to 10%, but greater than 10% of breast cancer is diagnosed in the age group of less than 40, and it also has a higher prevalence in the Ashkenazi Jewish population. So if a person already had cancer, why should we test the cancer survivor? So there are 3 basic reasons. The first is to provide information about risk for new cancers, not recurrence risk, but new cancers. The second is, so for example, in an individual who already has a breast cancer and is diagnosed with a BRCA1 or 2, they are at risk for a second new cancer, second primary in the opposite breast or in the ovary. Number 2, it impacts medical management and surveillance. So for example, prophylactic surgery may be offered to reduce the risk of developing a new cancer. So in an individual who had, for example, a contralateral, the opposite breast involvement, she may opt for a bilateral mastectomy to reduce the risk of developing a new cancer, or a oophorectomy, taking out the ovaries to minimize the risk of developing ovarian cancer, or more frequent alternative screening regimens. If a person had breast cancer and they are BRCA1 or 2, we may do more frequent screening, but there really isn't a good screening opportunity for ovarian cancer. And also, it might impact whether or not we decide on using chemoprevention, using agents which may prevent another cancer from coming back if we know that this is of forming, excuse me, if we know that this is the type of mutation. And of course, lastly, it provides information for at-risk family members. We like to do testing in somebody who has already had the cancer, because what this does is it helps us identify whether or not this has useful information for the rest of the family. Sometimes we even do genetic testing in individuals who are in palliative care or have metastatic cancer, not for the purpose of the patient themselves necessarily, but for their family members. So really, it's kind of one of those things where we look at cancer as accelerated aging, and this comical slide was talking about how we really just need to think about what's going on at the moment and how can we anticipate that it's going to project further. So here we have acute survivorship at diagnosis. Mr. T is a 55-year-old recently unemployed construction worker, and he's diagnosed with prostate cancer. And his body mass index is high, and he has a history of hypertension. So right away, we need to anticipate at diagnosis that he's obese, that this is a young age at onset, that he will possibly have concerns over his financial status, and that he's going to have possibly some sexuality concerns. He undergoes a radical retropubic prostatectomy, so he has his prostate taken out, and he's found to have locally advanced disease. And he's given a short course of androgen deprivation therapy, and he's also been advised to have that combined with radiation therapy. And now we have to anticipate that he's going to have some issues during and after treatment. There's a greater risk for sexual dysfunction, cognitive dysfunction, increased risk for worsening other comorbidities, bone health, incontinence, and again, insurance coverage and finances. We always have to think about the next step in order to advise our patients properly. And then, of course, the patient is all done with treatment and grateful to be alive and have successfully completed treatment. But they will come to your office and say, hey, doc, I did not bargain for this gynecomastia induced by the androgen deprivation therapy. I don't like the way I look, and this is really getting me down. So late effects can impact organs and vital systems, every single one, and we really need to think about which ones they impact and how it does it. And here I have listed every single organ system. But the one I want to have you think about today is cardiac late effects. And we've really come a long way in survivorship and in the medicine of survivorship, in thinking about how to bring cardio-oncology into the picture to prevent what this case actually highlights. So nearly 12 years ago, Miss O'Donnell found a lump in her breast. And at first, she wasn't worried. A routine mammogram a month earlier showed no signs of a tumor, and the lump grew so quickly during a 2-week vacation that Mrs. O'Donnell went to see her doctor days after returning home. The doctor ordered an immediate biopsy. The 42-year-old mother of 3 boys was diagnosed with advanced breast cancer and told she had only a 5% chance of surviving the next year. Now, she proved the doctors wrong. Yay. In 2008, though, Miss O'Donnell began chemotherapy treatments, underwent 2 surgeries, including a mastectomy, and was then considered cancer-free. So we're thinking about this as a victory. However, just 6 weeks after her chemotherapy session, her heart failed, which is a side effect of chemotherapy, the anthracycline. She underwent a heart transplant in 2010. That in turn caused other problems. For example, medication caused spinal deterioration, kidney disease, blood clots, which have resulted in hospitalizations and physical limitations. So her survival came at a very expensive price. Miss O'Donnell, now 54, has chronic health problems arising from her treatment. So what I want to emphasize here, it's kind of like the bad news, but from this bad news and from understanding late effects, we now are monitoring anthracycline. We have a whole specialty of cardio-oncology. We do imaging, we lower the doses, we take into account these things, and we monitor these cardiac effects so that it doesn't get to that point. Again, anticipation. Another area that I think you can make a big difference as a physician of any type, of any speciality, is in one of a very common endocrine toxicity which occurs, which is hypothyroidism. And this is a risk for patients who received radiation therapy to the chest or the neck, very common in Hodgkin's patients, Hodgkin's disease, and breast cancer. And it's always important to assess for this type of thyroid deficiency, which the symptoms can be complaint of weight gain or fatigue or hair thinning or cold sensitivity. And the reason that it's so important to check for this is because you can fix it. It's so fixable with medication, with thyroid replacement. to talk a little bit now about something in my survivorship lectures to medical students in particular, and to non-oncologists, because I really want to emphasize that you can take home from this next part of the lecture where I'm going to be talking about how lifestyle impacts diet, physical activity, and obesity modulate survivorship. And you're going to take home a prescription in the next 10 minutes that you can share with your peers, your patients, and your family that will really make a difference in their outcome. So that is that the way lifestyle modulates cancer survivorship is through epigenetics. And we have two types of, to oversimplify it, we have two types of genes. We got the oncogenes that turn on the oncologic process, and we've got the tumor suppressor genes that turn it off. And our goal is to take epigenetics. I think some of you have to go back to, your basic science, but we have methyl groups, and they attach to the DNA and they attach to histones. And you got acetyl groups that attach to the histones, and they can turn on and turn off genes. So for example, doesn't matter what you weigh. We're pretty certain that obesity does influence the epigenetics turning on and off the cancer genes for about 40% of cancers. And what we know that obesity and cancer survivorship, that not only is obesity, and by that we mean a body mass index greater than 30, is not only is it associated with a higher risk for these cancers, a lot of cancers, which I have listed, but also death due to cancer, and recurrence and mortality among breast cancer survivors, and growing evidence in prostate, colorectal, and endometrial cancer. And also I showed you those cardiovascular late effects. Well, that's more common in obese patients, and a higher rate of late effects in almost every second cancer. So what we need to understand is that adipose tissue is basically an organ, and it causes hormonal dysregulation. With in the breast cancer model, we look at it as increased estrogen synthesis, increased insulin resistance, and increased growth factors, which play inflammatory havoc. We're hearing a lot now during COVID about cytokines. Well, this is inflammatory cytokines are also a mechanism by which we enhance cancer. And so what we know is that even a 5-pound weight loss will decrease inflammatory biomarkers, potentially reversing a pro-inflammatory profile in cancer survivors. Now, there are compounds in foods that change the epigenetic marks too. And also lower caloric density foods promote weight management. So we think that it's not only the content of the fruits and vegetables that change the epigenetic marks, but also the fact that it promotes weight management. And for example, in cruciferous vegetables, there is an agent named sulforaphane, and that hinders methyl group attachment and removes acetyl groups, turning on the cancer suppressor genes. And I told you that I was one of the principal investigators for the Women's Health Initiative, and what we learned in the Women's Health Initiative, and also other studies, is that women who were on a low-fat diet, who were on the low-fat diet arm of the study, decreased their intake of fat and enhanced fruit and vegetable intake. These women lost about 5 pounds. And if they were developing breast cancer during the time of the study, during the 8.5 years that the intervention was taking place, they were less likely to die from it after 20 years of follow-up. And this actually 20-year follow-up just came out actually this week. And they were less likely to die of it than their counterparts who were not following who were on in the control group, who were not following this dietary intervention. So how does physical activity play into cancer survivorship? Well, we know from the Nurses' Health Study, studying over 3,000 nurses with breast cancer, that walking 3 to 5 hours a week decreased the death rate as compared to those who were sedentary. And we think that the reason that is that the tumor suppressor genes were turned on through that mechanism. So in general, through many studies, meta-analyses, physical activity confers a 15 to 61% reduction in the risk of death from breast or colorectal cancer. And just advising 30 minutes of brisk walking 5 days a week in the breast cancer situation, or in the colorectal cancer situation, 60 minutes 5 days a week, can impart a mortality reduction. So what about sleep? Well, sleep impacts epigenetics too, mostly through the pathway of decreased, through the metabolic pathways. And there's a perfect, and really it may be because individuals that have the perfect amount of sleep are have more energy for exercise and eat less, but there's a perfect amount of sleep, and that's 7 to 8 hours. Now, what about alcohol? The news about alcohol is that alcohol is carcinogenic and also increases recurrence, increased contralateral breast cancer, and increased cancer-related death. And so we really do not advise alcohol for our cancer survivors. And when we talk about a drink, you can see here in this slide, we're talking about one drink is 12 ounces of beer, 8 to 9 ounces of malt liquor, 5 ounces of table wine, or 1.5 ounces of hard stuff. And this picture denotes the half a glass of wine, particularly for that should be the limit for breast cancer survivors. So we can understand that we can eat to beat malignancy and really walk away from cancer, and that we can really help our cancer patients with lifestyle changes such as food, physical activity, sleep. So here's the prescription, which pretty much anyone can give, and after this lesson today, and that's really choose predominantly plant-based diets rich in a variety of fruits and vegetables. If eaten at all, limit intake of red meat to less than 3 ounces daily. Limit consumption of fatty foods, particularly those of animal origin. Alcohol should be limited to, for men, less than 2 drinks a day for men, and less than one a day for women. And we really don't recommend any alcohol at all for women, particularly breast cancer survivors. Do not eat charred food, particularly meat in direct flame, and that's because of the heterocyclic amines, which are carcinogenic. And avoid being overweight. Basically, we try and influence weight maintenance, and simply take an hour's brisk walk or similar exercise daily. It's important to actually show our survivors what we mean. And so this is the cancer survivor refrigerator. And this joke really is just trying to show that we need to be demonstrative about what it is that we mean, and we need to say what we mean. I'm going to quickly go through the supplement slide, because this is a very big misconception. We don't advise supplements for cancer survivors, but we do advise food. And the reason that is that supplements, nutrient-rich food has been linked to a healthy survivorship, whereas there is no evidence that that supplements are linked. So the tomatoes, the lycopene in tomatoes, the sulforaphane in cruciferous vegetables, the diindole methanes, which decrease estrogen from cruciferous vegetables, the anthocyanins from beautiful cherries and blueberries. We know that these are the kinds of things which do turn off the oncogenesis and turn on the tumor suppressor. The outside supplement that we do recommend is vitamin D and calcium. Vitamin D, 800 to 1,000 international units of vitamin D3, and for calcium, 1,200 milligrams of calcium citrate or carbonate. But the reason we recommend it is not for cancer suppression or recurrence suppression. We recommend it because most cancer survivors are at risk for osteoporosis, and this is to prevent that. So either through diet or supplementation, we give our okay for vitamin D and calcium as the only supplements that are advised. So here you see a summary of what I have been talking about in terms of lifestyle. Letting food be your medicine and physical activity is the medication you need to take daily. So we're going to move on now to anticipating the psychological toxicity. And during this part, I'm going to try and be a little bit more interactive. Usually when I give this talk in person, we go around the class, and this is all about narratives. So I'm going to introduce this aspect of psychological toxicity. Viva, if she's still there, is going to be calling on you at the right moment. I'm just preparing. Just all you're going to do is read some of the narratives when prompted to do so. And what I want to say is that, you know, when you're talking to patients, it's all about language. And the reason I'm saying this is emotional distress is common in cancer survivors. It can occur at various times. We need to anticipate, we need to know whether or not we need to refer. We need to talk to our patients and speak their language. And many psychosocial, emotional, and spiritual impacts of cancer, which I have listed here. But patients, again, come to us with their own language. And so, for example, one of the areas of language that is well known to not be discussed in medicinal health professional situations is sexual dysfunction. And it's very common in survivors, and it needs to be addressed. It's common in men, erectile dysfunction and lack of libido, and early menopause symptoms in women can bring this on, along with other changes in libido, vaginal dryness, pain on intercourse, body image changes. So the question has to be asked. And one of the things that I talk about when I do the resident and clinical evaluations is I teach health professionals how to ask the question. And one of the ways to do it is to normalize it and say, many cancer survivors complain of relationship and sexual issues. Is that a problem for you? And I think that way you have opened up the door. Instead of having it blurted out in this particular way, where I'm seeing a 49-year-old woman for a routine gynecologic exam, and her mastectomies were 7 years ago, and she's self-conscious being undressed and starts crying prior to the pelvic exam and blurts out, "I don't feel whole. My husband and I are having relationship issues." So we don't want these things to sort of come out to the breaking point. Okay, Um,
I'm actually here still, I am still here, Dr. Rosenberg. I apologize if you called me. My audio kept coming in and out.
oh, okay. Well, we're going to go to
Here
this.
for your segment.
We're going to go to this slide. Let's see. Fear of recurrence. And so I'm going to start out with this narrative, but the rest of the narratives, I'm going to call on you, but these are taken from my practice over the years, quotes about how cancer survivors responded or expressed themselves to me. And what you'll see is that the language of their survivorship is fairly sophisticated because they're all Northwestern University college professors. So my practice was in Evanston, and so that was the language of their survivorship. And so depending on the socioeconomic and demographics of where you are, these things come out in different ways. So in this case, a 48-year-old female underwent a lumpectomy and radiation for a very low grade, or basically now stage 0, we don't even consider it cancer, breast cancer 6 years ago. And she comes for a wellness exam, and the first thing she says to me is, I can't stop worrying about my cancer coming back. Okay, that's very straightforward. That's a way fear of recurrence may be expressed. But now we are in this. So are we going to call on people?
Yes, I'll call on people in no particular order. So Andrew, since you're the first name that comes to mind, Andrew Gross, would you mind being able to read this quote for us?
Sure. I still don't renew subscriptions for 3 years, just annually.
So this is a way that somebody is a question, a way that they are expressing their anxiety, and it's fueled by their cancer experience. Next. Grief.
I apologize again, my audio. So David, would you be able to read this for us?
Yes. Givens are no longer certainties. Life is no longer infinite. Health is no longer assumed. Death is not for someone else, but for everyone.
And what that really is expressing is a sense of loss. Next patient. next quote.
Okay, Ellen, would you be able to read this for us?
Yep. I also cried because I would not be coming back to that familiar radiation table where I had been comforted and encouraged. Instead of joyous, I felt lonely, abandoned, and terrified. This was the rocky beginning of cancer survivorship for me.
So this is what we call the cancer survivorship paradox. When individuals are under treatment, they feel coddled and cared for by radiation, medical, surgical, oncology teams. There's a lot of attention. You walk off that familiar radiation table that Dr. Golden knows so well, and you feel abandoned. You feel, you're happy you're done, but what's next? Next quote.
I apologize. Valerie would be able to read this for us about body image and self-esteem.
Yes, I can. Body image encompasses more than my physical attributes. It describes my overall wholeness, functionality, and ability to relate to others. Body image is part of my self-worth.
So what we're seeing here is really the discrepancy between the way someone formerly perceived his or herself and how they see themselves as a result of cancer and its treatment. And I would have to say that it isn't really necessarily about losing an appendage. It's about a sense of loss that is very, very primal. So individuals, and we all know people that think that they're this, even though they're not this, and this muscle builder, but it's that sense that we want to reconstitute in the survivorship phase, or an individual who has a personality. It's our inner self-image, it's our inner body image that really needs to be reconstituted in the survivorship phase. The next quote, please. I want to say that this, when we're talking, this individual who did this quote is Irma Bombeck, who was a writer for the Chicago Daily News, and a long time ago, a very, very beloved writer who we all watched go through the cancer experience and ultimately succumb to it. Okay, so someone please read.
Maria, would you be able to read this for us?
Yes, I can. So, existential issues. Face it, you've got to be like me to really appreciate how silly it is to read a letter from Dear Abby's Colin about a woman upset because her neighbor hasn't returned her salad bowls. It's like, oh lady, how can you stand it?
And so, you know, this joke is, you know, these individuals don't have time for a midlife crisis. And what we see oftentimes is a psychosocial issue which is positive, which is post-traumatic growth, that sense of self-esteem and mastery after going through a survivorship. And please read, whoever was reading, Maria, or please read this.
Sure. But mostly, given another shot at life, I would seize every minute. Look at it and really see it. Live it. And never give it back. Life is too short to let it pass you by.
And what I want to tell you is that these individuals, when they express themselves like that, they make you understand how precious life is and how important life is. And they really bring meaning to our purpose and our work as health professionals. Okay, on next quote.
Ryan, would you be able to read this for us?
Sure. Our fear of death makes it essential to maintain a distance between ourselves and anyone who is threatened by death. Denying our connection to the precariousness of others' lives is a way of pretending that we are immortal. Yet cancer connects us to one another because having cancer is an embodiment of the existential paradox that we all experience. We feel that we are immortal, yet we know that we will all die.
And I think survivor guilt is really the question, and you could see that this is a college professor, but what he was expressing so eloquently is that the question, why did I live? And the person who had the same disease next to me, who was sharing chairs, who I waited with in the waiting room all this time, didn't make it. Why did I have the roots to weather this storm? I feel guilty about it. Next, and what I want to preface this next narrative about is that I want you all to remember that cancer is a family disease. Somebody please read social impact.
Maggie, would you be able to?
Sure. He just doesn't seem as though he can forget about it and just lead a normal life. It's curtailing our life. It's something I wish that he would get over, but I don't think that he's going to.
And that's the spouse of a survivor. And what we know is that, as I said, it's a family disease. We relate to all of the people. Survivorship is a family issue. At every stage, we need to make connections, and it has a social impact. And what we know for certain is that reclusiveness is deadly, higher mortality rates than individuals who are able to reconnect after the cancer experience. Somebody read this, please.
Apologies. Kevin, would you be able to read this for us?
Sure. We do a lot of waiting, a lot of resting, a lot of waiting and a lot of resting. When you love someone, you just kind of hang in there and let whatever the courses take hold. I want my real mother back.
So here you see the spouse of a survivor and the daughter, age 5. All about family and reconnecting. And this is what I want to say, that you should always, throughout your a medical career understand that cancer is a family disease. And we all need to reconstitute those relationships, and those relationships change as we go on. So what is the new normal for cancer survivors? Well, really what I want to say is that the new normal is important for you as health professionals, as young health professionals, to understand that there are 3 vital signs for a healthy survivorship, and you really need to start with that, and that is having a sense of purpose and reconnecting in social relationships and a positive lifestyle. Those are the 3 first vital signs. And this individual says, I lost my breast, not my brain. And exclusivity in job lock and lots of things going back into the work family can be very isolating. And this is a big toxicity that plays into the financial toxicity of cancer survivorship, namely job lock, not being able to change what you're doing, but also if you have to be on disability, there's the price of cure and there is the price of treatment, and it doesn't stop after treatment. And it incurs very high socioeconomic situations. And what we know is that the financial toxicity experienced by patients, by survivors, continues following the cessation of treatment. And this slide appears comical, but the out-of-pocket expenses are higher than those of age-matched controls. And there's higher debt, and there's lower discretionary income, and there's emotional distress. And sometimes really all you do need is a little retail therapy to make the day go better. I would like to, Aviva, can I take a few more minutes because I really want to do this case study to bring it all together?
I think that would be fine. Dr. Henderson, would that be all right with you if you talk us delayed by a couple moments?
Sure. I can't go much past 5, but that's fine.
This is, hi, Tara.
Hi, how are you?
I'm good. This is going to take 3 minutes.
Okay.
So in this case study, this is a survivor of renal cell carcinoma, and we're just going to run right through this because I want to show you that even in your young health professional lives, you will be able to fix this problem. So Giodia Sarkanian's 38. She's got 3-year survivor of renal cell carcinoma, and in 2017, shortly after she married, she was on a skiing trip and she sustained injuries, including a rib fracture. And in the course of evaluating her injuries, her physician detected an early stage of renal cell tumor. The kidney was removed, it's all gone. It didn't, just had to maintain annual exams, but she has not been able to return to work as an elementary school teacher. And she comes today during a routine annual exam to her primary care physician's office. And she's anxious and depressed, and she hasn't come for more than 2 years. And when she's examined, Dr. Smith finds a 20-pound weight gain, but no other significant medical findings. And she becomes tearful and explains that she has never gotten back to normal and lives in constant fear that her cancer will return or that her remaining kidney will fail. And she states, I've been terrified to think of becoming pregnant because, and this is causing great marital distress because her husband is eager to start a family. And then she admits to starting smoking because of her overwhelming anxiety about her health. Uh-oh. Where did I go here? Okay, so overall, how would you describe Mrs. Sarkanian's psychosocial needs? Her concerns are expected for anyone surviving cancer and do not require intervention. Her physical problems should be addressed, but it's best to ignore emotional issues. It's best to address the psychological problems, but ignore the physical concerns. Her concerns are common for cancer survivors, but require intervention. In the interest of time, I'm not going to wait for an answer. I'm just going to put it up here and hope that you selected number 4, which her concerns are common for cancer survivors but require intervention. In meeting Ms. Sarkanian's needs, they will be most successful if her needs are addressed only by her primary physician to avoid confusion among multiple professionals. She'll likely benefit from collaboration between her primary physician and psychosocial professional. If she's referred to a fertility specialist and if she becomes pregnant, her other problems will resolve. All psychosocial support is best left to the subject. And I hope that you chose she will likely benefit from collaboration between her primary physician and a psychosocial professional. So what we understand about the prescription for survivorship is that we always need to assess our survivors' vital signs, connection to social engagement, promoting positive lifestyles, that we need to be able to anticipate, assess, and identify the long-term and late effects, both physical and emotional, of our patients. That it's not just us, that it's all the collaborative kinds of services and diagnostics that are important to enhance the long-term cancer survivor. And that, of course, we need to do survivorship care planning with our patients, which we do through a survivorship care plan. And that is one of the things that we do in our survivorship program. And what we really need to know is that we want to address what's important to our patients so that they can live in the future. So those of us who work in the cancer environment, we understand that everyone is at risk, and we really can't conclude that we're not at risk, that we just have to live with the fact that we're all at risk. But we do need to emphasize that being able to anticipate, assess, and identify not only us being able to do that, but also our survivors, that we really need to set up an environment where knowledge is power. You know, one of the things that we know is that as the raw intensity of treatment subsides, a way emerges to go on with life, and ordinary people end up doing extraordinary things in the cancer survivorship realm of care. And I want to say that really what is important is that your job as a health professional at every level of your education and practice is to help individuals look forward into a future that they can live productively with a good quality of life. And that is really the goal. And we must be willing to tell our patients to let go of the life they have planned so as to have the life that is waiting for them. And I wish you all a very productive medical career. And I know that you will be amazing in whatever it is that you do. And I hope that this has developed for you a conceptual framework that you can move forward, helping yourself and your patients living in the future.